what I can present to you there. There was a lot of talk about, the attitudes of open dialogue and the changes in the minds which are important to them. And on the other hand, there was some talk about the financing as well. And well, actually, in my presentation, I want to bring these two sides together a little bit as well, because I think both of them are very, very important if you want to do any changes in the mental health care system. And so I will first outline the main characteristics of our regional project, which in the beginning was really a new way of budgeting with only vague ideas how to use this further on. And then I will demonstrate how this form of budgeting can create the space for deep changes in the regional organization of mental health care. And I will conclude to talk about how the integration of open dialogue helped us to take up the opportunities that the regional budget offered to us. So let me start, please, to have just a few words about the situation in Germany. Although there is there's clearly recognized on an international level now that flexible and integrative treatment models provided by multi-professional teams are fundamental to an adequate health care nowadays, and we heard a lot about this today. The situation in Germany is that such teams, outreach services are very underdeveloped and are not available to most of the population, really. And this is because the system in Germany can be described as very fragmented. Patients with severe mental illness receive separated in- and outpatient care with little context between each other, and with a high emphasis on inpatient care still. And this situation, of course, has been recognized by many experts and those who work in this field, and over the last 13 years, about 20 projects have been launched for multi-sectoral care. This development was also been supported by a law that demands such pilot projects should be implemented in all federal states. And all these projects have distinct features which are due to local factors, so it's very hard to talk about general characteristics of them. So I will today speak about our project in the district of Steinburg, which is right in the north of Germany, in Schleswig-Holstein. And in fact, this has been the first of those projects, which started in 2003 in Germany. And the activity of the head of our department, Arno Deister, had a big impact on the legislative initiative and the development of all these other projects. I myself, I'm working there as a psychiatrist and psychotherapist for more than 20 years now, and for the last 10 years I have been responsible as a consultant for treating patients with psychotic disorders for the team, which is responsible for this. So, when we're talking about the regional budget, we are talking about a multi-sectoral financial model for psychiatric and psychotherapeutic care, and I will explain in more detail what this means in a minute. Before that, I will give you some details about the region and the political and organizational background of the at least hospital-based mental health care system. In Germany, the Bundesländer, the federal states, are responsible for the planning and financing these hospital structures and giving some guidelines for them, how many hospital beds are needed, into investigation into the structure and so on, and the actual planning and is due to the districts. In Schleswig-Holstein, state policy has strongly, this is the Bundesland, the federal states where our district lies, and it has promoted regionalization since the 70s, and our project over last years has gained a lot of support from local politicians, actually regardless of the political positions and changing governments over the years, which is a very good thing. And in Schleswig-Holstein, all the districts now form a catchment area of its own, and with a regional responsibility for psychiatric care. Most of the districts have departments at a general hospital that take over this responsibility. So, oops. Next one. Maybe I should, say a little bit about the next one. Yeah, the district of Steinburg, the catchment area is about 130,000 people, and the town of Itzehoe, which lies right in the center of the district, has about 30,000 people, and there are some smaller towns in there, and the district has a mixed structure with both rural and small town areas. It's not in Hamburg, Regina, it's 60 kilometers out of Hamburg, still part of the so-called metropolitan area of Hamburg, but a lot of people actually travel daily to Hamburg for their job, but in the hospital, it's the other way around. Many people, especially from the academic staff, doctors and psychologists, travel each day from Hamburg to Itzehoe to work there in a hospital. And due to the position on the outskirts of the metropolitan area, we are confronted with a, somewhere even increasing shortage of qualified medical staff during the last years. This is one major problem we have. Well, the General Hospital is a community-based hospital run in a joint venture of the district and the city of Itzehoe. And as a community hospital, it is a non-profit organization. It has about 700 beds, 10 medical specialties, and it is one of the biggest employers of the region. The psychiatric department was founded in 1975 and actually was, there's some discussion if it was the first or the second of this kind of departments in Germany. And this was at the time one of the main initiatives for the regionalization of psychiatry, to build up departments at the general hospitals and to close down the central asylums, really. Today it has about 60 inpatient capacities for inpatient treatment and about 70 places for day clinic treatment, and it also delivers outpatient care and home treatment. So let me now explain some details of the rationale of our financing system. If you look at the total need for regional care for psychiatric problems, in Germany you have 3 sectors which are providing this. On the left side, you can see outpatient psychiatric and psychotherapeutic care, and this is delivered by private practices. And the treatment is funded totally by the insurances, so no one really has to pay for them. But at least in a region like Itzehoe, which is not in a metropolitan area, you have certainly a shortage of places. So it's normal to have, we heard this, to have a waiting list for 3 months or even longer to get an appointment for a psychiatrist, and for appointment for psychotherapists it's even longer. And for some people, like people with psychotic disorders, it's nearly impossible to get a place there. Then on the other side, on the right side, which is that other community-based services, this is what, again, social psychiatry, sozialpsychiatry. These are, they cover supported living and occupation, but also A lot of them run some outpatient services as well and homegoing services. And then you have the hospital sector, which certainly gets a lot of money, and today it's not only inpatient care, but it's outpatient care as well. And some hospitals now, like ours, do home treatment as well. As you can see, there's a lot of overlapping between the sectors. But like, you know, today I can only talk about the hospital sector there. Unfortunately, as far as I know, there are no projects like in Koszalin which really take all these sectors into one budget, which is really a big pity. So you have a lot of loss of resources there, I think. So, the core of the regional budget is a contract between the hospital and all insurances for the treatment of all people with mental disorders in the whole region. And this is important because so all people living in the catchment area can be included. Instead of pay for performance, like, you know, the number of cases or days in the hospital or diagnostic related groups or anything, a fixed annual budget, so to say a lump sum, is agreed. To realize this budget, a number of patients is agreed upon. And all we have to do to realize this budget, we have to treat this number of patients within a year, so that we get all of the money, but it is totally our decision how to treat them. It might be that we treat a patient from the 1st of January to the 31st of December in an inpatient basis without any break, or we just see him one time as an outpatient. They all count the same. This is totally to us how we do this. The idea behind this is, of course, to change the kind of incentive for selecting the treatment. In routine care in Germany, it is this incentives favor inpatient treatment because you get the most money for them. And if you do a lot of treatments, a lot of things, and a lot of programs, you get more money. So, and this is normal when you pay for hospital days, then the hospital as an economic enterprise will deliver hospital days and try to deliver more hospital days. And actually this is something which still is happening in Germany with, in many sectors, again, an increase in hospital beds. And this is a very bad development, really. And so let's see what happens if you take away this kind of incentives, like in our budget. Well, whoops. I see if I can take this back. Yeah. As you can see, in 1996, just way before we started our project, this was just inpatient treatment in the hospital. And when we started the project in 2003, there was also outpatient treatment and day clinic treatment. But 10 years after we started the project, the proportion of the inpatient treatment had nearly halved, and the others grew more. Oops. It doesn't go. Oops. So this is another way of, in the beginning, there was nearly 120 beds, which was quite a lot for the population. And in 2017, there was only 60 beds for inpatient treatment. On the other hand, the number of day clinic places more than doubled. So this is the number of patients we treat each year. This is the number we agreed upon. And you can see this is very stable over more than 15 years. And this is without doing much to it. It's just stable. And the yellow corridor is the corridor of patients. We have to, if we would be treating more than above the corridor, we would maybe get some more money. If it was really below them, it would be bad for us. So, and this is the average length of stay in hospital, which dropped from 25 days in 2002 to 11 days. And this is not the single stay, this is the cumulative number of days per person and year. So it also includes if a person is admitted for several times. This is also included in this number. So this is quite a dramatic increase. So this is just one summarization of these results again. You have a decrease of hospital days and a decrease in the length of the hospital stays on the one hand, and you have an increase of day clinic days. And well, I think this is especially important. A number of persons that are treated on an outpatient basis only increases as well, so they never go into have never gone into the hospital in the year. There has been a research project evaluating this model project for the first years as well, and in there was a comparison of 500 patients with those of a neighbor district delivering care under routine circumstances. And no significant differences in the development of psychopathology and quality of the life were found. This means that the reduction of hospital days did not cause the reduced outcome. So this, of course, was one of the concerns of the insurances, that we just would not treat patients properly if we didn't get the money for that. On the contrary, there was some evidence that for persons with severe mental disorders like psychotic disorders, there might be some advantages regarding the level of functioning in this. In addition, the reduction of hospital treatment was not due to the shift of costs into other sectors. But to be clear about this project is not about saving money as well, but to use the money more efficiently. So far, I have tried to demonstrate how a change of the financing system alone brought along profound changes in the treatment system. So what I've presented so far can be seen as, well, representing a kind of a mental turn. Normally, an increased number of patients, cases, and so on brings additional resources in the system. In our system, it is efficient treatment that releases resources that, and this is important, stay in the system. And they do not drain to some external stakeholders as a profit or so. So we can use all the money, we save all the resources to improve our treatment. So to put it this way, we don't want to treat other patients, we want to treat our patients differently. And now I want to try to show how we try to use these resources to improve the treatment. When I took over responsibility for the Psychosis team more than 10 years ago, I soon felt uneasy with what we were doing. There was what was quite a traditional way of working there, really, with a lot of emphasis on medication and institutionalized helps, and I felt that there was not this strong stressing on recovering and not a big network perspective on things. And although the results of the research indicated that a more flexible treatment could be especially helpful for people with psychotic disorders, I felt that we did not make enough of our changes. So at this point, we started looking around for new concepts, and in 2008, I think it was, we met Volkmar Aderholt, and he brought us in contact with Open Dialogue. And, well, in some way, I think for many people in Germany, Volkmar is a little bit like Regina for Poland. Most of the people had their first contact with Open Dialogue with Volkmar. And I felt that there was no treatment system that had been proven to be helpful for people with psychotic disorders, and that was based predominantly on an outpatient and homegoing outreach service, and represented a different treatment culture. So I attended with another German group. We had an excursion to Tornio. Volkmar was with us, and Werner as well. And after that, I was convinced that open dialogue and the regional budget had a lot in common. Or let me put it in this way, I felt that the organizational structure of the regional budget would make it easy to install some of the principles of open dialogue. And I now want to demonstrate this by comparing the principles of open dialogue with the characteristics of the regional budget. First, for immediate help. There's a very low threshold to enter our treatment because there's nothing like an enrollment procedure. As all insurances covered, and you have to be in health insurance in Germany, you basically only have to be an inhabitant of the district, have a relevant mental problem, and get into contact with us. And then treatment can start right from the beginning. And then the main restriction might only be our capacities. Flexibility and mobility. The regional budget provides excellent conditions for a high level of flexibility and mobility. There are no economic incentives, as I said, for inpatient treatment. In fact, one could say the opposite is true. There are no bureaucratic barriers between the treatment setting. For example, a person might start with an outpatient treatment on the one day, may spend the night in the hospital, and may go home the next day and be visited at home by the treatment team the day after without any need for bureaucratic procedures, really. And this is absolutely a great help. Psychological continuity. Well, again, the lack of barriers really helps in there, but this also needs a lot of reorganization, as we learned, of the treatment processes and also changes in the mind of the people working there. And this is still one of the major challenges we face within a hospital setting, with the normal fluctuation within staff, shift schedules, and so on, which everybody knows who's working in a hospital. Team's responsibility. Well, this again was clear that it needed major organizational changes, but also a change of treatment culture that had to be addressed in training. The same was true for emphasizing the network perspective, and of course, tolerance of uncertainty and dialogism are in the core of open dialogue and of open dialogue trainings. So, how did we go on from there? Let me show some of the landmarks. We, and a lot of members of the team took part in external trainings, national and international network meetings, and we had 2 in-house trainings with about 50 trainees so far from all professions. And I think this is really the core of the developmental process, because it started really a process of discussion among the members of the teams about treatment philosophy and between all professions and all hierarchical structures. So this had, I think, had a big impact on the, to be more on an eye level between the team. And it was strengthening especially the role of the nursing staff, but also on the other hand, their responsibility got bigger, and some of them liked that, some of them not. So, although not everyone who took part in the training really afterward went on to practice open dialogue, and did network meetings as moderators or facilitators. This still, I think, was a very, very valuable experience for all who participated, and very, very important for the development of the department. But open dialogue became a central point in the treatment philosophy of the Psychosis team. And nowadays, network meetings and treatment conferences are daily routine really for these teams. I want to put a special reference here now to the treatment conferences, something which might not be known to many of you, but they had a major impact on our development of dialogical practice, so I want to explain a little bit more about them. This is a model of communication between patients and treatments that was developed by Volkmar and some colleagues in Hamburg, and he told us and taught us about this in our first in-house training, or even before, I think we started with them. A treatment conference is a weekly meeting of the patients with a team during which the treatment process can be reflected and relevant decisions are discussed. This, of course, follows the idea that the patients should be included in all relevant treatment decisions, and thus can be seen as an instrument for cooperative decision-making. This conference usually lasts about 20 to 25 minutes and includes a reflective talk of the team members, which is done according to the recommendations of open dialogue. For us, treatment conferences were the place where we first could practice dialogical attitudes and skills, like the way of listening and responding, attentiveness to the way we use our language, sharing our thoughts with each other in front of the clients, and so on. And still today, it's very often the first contact of these practices when new team members enter, or some guests from outside come to visit us. And in our team, they totally substituted the former traditional ward rounds. As a result, the communication with our clients became much more collaborative and on an eye level, likewise between the team and the clients, and within the team as well. And with these experiences we had met, we felt much more confident than to go on and hold network meetings and even go home to the homes of our clients. And when we started with the treatment conferences, we were a little bit frightened that patients might be intimidated when they were confronted with a majority of team members. But the experience is that most of the times they feel quite at ease with the situation, and they appreciate their stronger influence on the decisions made, and especially they appreciate, and if we sometimes forget the reflective talk, they really ask for it and say, well, you have to do a reflective talk as well before we end. And this impression was confirmed by a small research project I did for my thesis during the training course in Espoo last year. For this, I analyzed a number of treatment conferences for their dialogical quality, and in short, the results showed that patients not only do most of the talking in these conferences, but they also have a major influence on the topics discussed, and very often the team manages to respond to these in a dialogical way. Let me now turn back to some of the structural changes that accompanied this. In fact, they were necessary to make the changes possible. This again was a long process, as we heard before, sometimes going back and forth. The closing of 2 wards was made possible by the reduction of hospital treatment that set free personal and financial resources which we could use for steps like the opening of the acute ward. And many of the changes can be put under the headline substituting the traditional ward, the place, by the treatment team. The idea behind these changes was that at the end, all teams should be responsible for all stages of the treatment process for those clients that are allocated to them, which in turn also means that team members have to work in different treatment sectors, which is a challenge as well. It can be very rewarding for many, but for a lot of them it is still a challenge. Another very important step was the implementation of a small multi-professional outreach team since 2015, or actually I think it was the end of 2014. And this is somehow integrated with the psychosis team, though it does not only work with people with psychotic disorders. And what it changed, having this possibility, is to really put a much more focus on the network orientation, and that it made it possible to provide immediate help and taking over responsibility. We experience this as a great expansion of our therapeutic possibilities, and it produces a lot of new creative ideas for the rest of the team as well. And going into the homes of our clients, and I think everybody who does this notices, or rather say, having the privilege to be invited there, or at least being tolerated, to be a guest makes really a significant difference in the context with the clients. At the end, I want to share some of the experience we have made on our way. I have to admit that I cannot really present much scientific data because we are not a research unit. But I can really say that there is deep change in the understanding of our roles. Now we ask less what is his or her problem, but rather what are his or her needs. Skip this. The changes we have made are intended to make things better for our clients. And therefore it would be very good to have data and to have research. But at least we have taken part in research over model regions as a whole. The main focus of this research was to find criteria to distinguish those model projects from routine care from the perspective of the users. And this was qualitative research using extensive interviews and focus groups with clients, relatives, and staff members. One of the results was that the clients recognize clearly and appreciate the changes that distinguish the work in model projects from treatment as usual. And psychological continuity seems to be especially important for them. And this effect was stronger when the changes in the projects were deeper and involved more fields, and the project was running for a longer time. So this was an encouragement for us to go on this long and sometimes tedious way as well. And one other thing I think which is very important is that we often make the experience that with a high level of flexibility we can offer, we manage to engage people into processes who have fallen out of the system before, who just wouldn't have stayed in the hospital, run away, didn't want to have contact. And now with all these possibilities we have, we can reach those people. We believe so that the changes I have talked about can really make a difference for the clients. And for this, I think it's maybe appropriate to conclude with a remark of one client which kind of touched me really when I get this. This was a man who had a very complicated history with us. He was admitted on an involuntary basis before in first hand, stayed some time, and afterwards we had more than a year, a lot of intense exchange of letters with each other where he complained about the injustice that had been done to him and forth and back. And in one of his last letters he wrote, eine Behandlung hat nie stattgefunden, wenn Sie sich damit anfreunden könnten, stattdessen eine Begegnung mit respektvollem und herzlichem Gruß. And I wrote this in German because I don't find it so easy to translate it and to get the real meaning. Maybe it's something like, there's never been a treatment. Perhaps you could agree that we have met each other. So I want to close with this. Thank you very much.